Hello and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Zachary Schwartz. I'm excited about this episode because today we're asking ourselves to look in the mirror. What are the barriers that stop healthcare providers from prescribing PrEP? What are the systems that make it difficult for people wanting to take PrEP? And how can we overcome those barriers? To answer these questions, we're joined again by Dr. Bedimo from the University of Texas, UT Southwestern. For more information about Dr. Bedimo, including downloadable slides you can use to follow along, please visit the links in the show notes. And to get access to all of our new podcasts, subscribe to the CCO Infectious Disease Podcast on Apple Podcasts, Google Podcasts, or on Spotify. Now let's get started and join Dr. Bedimo.
So addressing provider barriers. So let's look at ourselves in the mirror for a moment. Potential provider barriers to PrEP, low awareness and lack of comfort with it. So those two things we need to address. So everybody should have a modicum of knowledge of PrEP and feel comfortable discussing sexual behavior and HIV risk. There is no effective way to quantify somebody's risk of acquiring HIV. So it's important to be very liberal in prescription of PrEP. So anticipated unintended consequences like resistance, safety, behavioral disinhibition, i.e. risk compensation, are to be discussed openly. And provider-related stigma, we also do have stigma. Once somebody requests PrEP, we look at them differently, and that limits their willingness to ask for it. And, ambiguity about who should prescribe it, again, these are people who do not have HIV, so there's no reason why they should be the domain of HIV providers. So everybody should provide them. Again, logistical concerns. There's just limited time to do everything else, and there are insurance coverage and other things that we talked about, navigators and clinic champions. We need to just look at what environment is and how we can optimally use it. So mechanism to improve conversation about PrEP is to normalize PrEP as a preventive option for any person who is or plans to be sexually active, period. And it should be a shared decision-making. We build rapport, and then you look at how other things in that person's life may potentiate or inhibit the use of PrEP, including avoidance of a stigma. So set up clinic, safe spaces in clinic to do this. It's just not easy to discuss sex and sexual practices and prevention of HIV in a place that doesn't feel private or safe. So tips on taking sexual history: promote comfortable and non-judgmental environment. Do not assume gender identity, pronouns, sexual orientation of patients and their partners, or types of sexual activity in which they're engaging. Avoid unnecessary information, i.e. number of partners or frequency of sex. Things like, are you having sex, or who do you want to be having, or do you want to be having sex, or what type of sex and what body parts are you using? Those are the things that are direct and helpful. So you're gonna know if somebody has vaginal exposure, anal exposure, they're having oral sex, because prevention of HIV and other sexually transmitted infections depends on the body parts affected. And misgendering people is usually a turn-off for patients, so it's important to not assume those pronouns. Addressing gap in PrEP training, again, really, this is not rocket science. Analysis of surveys of 351 providers from 224 clinics in 18 southern US states and Washington, D.C. looks at comfort with PrEP screening, follow-up, and initiation is low, and that model suggests that 3 ways to customize provider training to increase self-efficacy is anchor in family planning training, train on insurance navigation, and address attitudes and concerns. So it's important to note that, when you integrate PrEP in other activities, and if you have careful discussion of how it can be used and who will be paying for it, it normalizes it and it makes it more acceptable to people. So positively associated with PrEP self-efficacy included factors that improve provider-patient confidence. So overcoming structural barriers, a little less, things that we can address. We're no longer looking at the mirror, we're looking at the structure that we are a part of. So insured patients are 4 times more likely to use PrEP. So that goes without saying. So, it's not in our purview to provide them with insurance, but to figure out those who are uninsured, how we can find them as solutions and options for PrEP provision. So it's important that people, 43% in this study in Washington State, had concerns about the cost, and others were uncomfortable discussing cost and insurance issues because they didn't think that it was a worthy discussion. It just like, insurance for other diseases. And then the U.S. Preventive Service Task Force think PrEP daily oral long-acting cabotegravir, is a grade A recommendation and should be covered. So that's important. Since that came out, it's important to make sure that it gets covered. Okay, so this is a barrier because there could be laws. We ought to be, the onus is on us to figure out what our patients face as structural barriers. As of 2022, all jurisdictions have laws that explicitly allow a minor of particular age to give informed consent to receive STI diagnosis and treatment services. That's the plus. But consent laws vary across some states. So in some states, minors are allowed to give informed consent to receive specific STD and HIV services, including PrEP. So it's important that we're familiar with those, and parental insurance coverage may not guarantee confidentiality for minors. So an healthcare provider should be familiar with the local or state policies, including age of consent and permitted treatment services. Now, we now have issues, of course, in some states now with significant concern about, providers worried about whether any provision of care, including contraception and others, can place them at the crosshairs of the law. So 2021 CDC PrEP guidance, key monitoring updates. So a PrEP candidacy, receiving HIV testing, assess HIV status at follow-up visits every 3 months, and HIV RNA assay is recommended. This has been a sticking point. Doing HIV RNA testing in addition to antigen antibody has limited the access to PrEP in some regions because getting this assay is not only expensive, but may not be available in some settings. The revised renal monitoring is every 12 months oral PrEP if age less than 50 and EGFR or creatinine clearance is more than 90, and every 6 months for older people or those who started with lower renal function. And also for FTC TAF, because it can increase lipids, so we should be monitoring lipids every year. Yeah, so it's a problem because many people not only may not be able to afford that RNA testing, but it may not be available. So the good news is that this is being revisited and that guidance may change. That's all we can say for now. So challenges with HIV monitoring while receiving PrEP, high rates of missed HIV testing have been found. Nearly 1 in 3 prescriptions fail without antigen antibody assays for the previous 3 months. That's dangerous because if you're not testing the people on PrEP for HIV, you might be giving PrEP while they're already getting HIV. So PrEP users who receive less testing are more likely to have public insurance, rural residents, North Central US, younger age, and females. So we need to make sure that PrEP comes with some stringencies. We need testing for HIV as well as other STIs. So real-world cohort of 30,000 PrEP users receiving PrEP, 9,090 combined HIV antibody assay and RNA testing in 5,391 individuals. So if you look at that, 99.8% of the tests between antigen antibody and RNA were concordant. So this data suggests that it's really probably unnecessary to do RNA testing in addition to antigen antibody testing, especially when you're using oral PrEP. So these discordant test results, there were 14 that had antibody negative and RNA positive. and 6 tests, antigen antibody positive and RNA negative. So no case of long-acting early antiviral inhibition or Levi syndrome were observed. So it's talked about, but it really doesn't occur that often. So it's possible that the CDC might remove that requirement to do HIV RNA testing in addition to antigen antibody based on this type of data. So PrEP Navigation Champion, they promote PrEP uptake and persistence. As we discussed earlier, initiation of PrEP, half of the people will discontinue in a year. That's really high. And we need to make sure that management and support of people is important. So designated PrEP champion is important. That strengthens the communication. Leadership uses proactive approach to increase PrEP retention and then train providers. So increasing PrEP uptake and retention with peer health navigation for transgender women specifically. That peer navigation based on mechanisms of social cognitive theory to improve participant self-efficacy. So staff with socially and well-connected community members. People feel comfortable when they see people who look like them, when they're on walk of life, who advise them on what we want them to do. So they're promoting community engagement with peer health navigators, so HIV. This is Alexis project that created a link, needed to link and retain transgender women of color in HIV care. I use health navigators, peer health navigators with a rewards schedule. So they increase session attendance and share with significant achievement of HIV milestones. So then wraparound services and peer health navigators, they integrate HIV prevention with gender affirming hormone therapy and other things. So we need to use whatever tools available. So success with PrEP champions, navigators. So we got the SNAPS PrEP navigation program in Bellevue in New York City. Navigators are placed in sites with frequent STI testing, but infrequent PrEP use. And compared to those without those with post-SNAPS, they had higher rates of PrEP initiation, a significantly lower mean medication possession ratio. So these things happen. SNAP is a great acronym: surveillance, navigation, accelerated follow-up, point of care, counseling, and seamless comprehensive. So potential solutions for PrEP persistence, you have peer navigations, use of telehealth, especially the pandemic has expanded our understanding and use of telehealth. Let's take advantage of it. And then there could be a way of getting patients to do labs at settings closer to them so they don't have to travel all the way to your clinic if that's not necessary. Now, immediate PrEP initiation, same-day PrEP, these things exist and improve use, as well as expanding PrEP options for all. So same-day PrEP initiation, just like we talked about same-day ART, there are reasons to consider that because it improves retention and access. And it's important that there are still system barriers and patient considerations. So we may worry about the safety of the medication, such as patients with renal dysfunction. So phase 3 study watch expanding PrEP options. We had, purpose 1 was lenacapavir every 6 months, plus or minus TDF, and then purpose 2, lenacapavir for cisgender men and transgender individuals. So the bottom line is this. So we have ever expanding options for PrEP. I don't want you to take the specifics of a specific study, but after daily oral PrEP in 2012, we have long-acting injectable cabotegravir every 2 months. And we might soon have every 6 month options for PrEP, or maybe even longer with implants.
Thank you very much to Dr. Bedimo, and thank you to our listeners for joining in. As a reminder, to view the full program on contemporary HIV treatment and prevention 2024, click on the links in the show notes for this episode. And please be sure to check back for more episodes on important infectious disease topics. Thank you, and we'll see you on the next podcast soon.